So now that we've introduced ourselves, I'd like to introduce Dr. Shannon McDevitt, who will be presenting to us remotely on STI services in primary care settings. Dr. Devitt is a physician of the Office of Policy and Program Development in the Bureau of Primary Health Care at the Health Resources and Service Administration. She has 15 minutes for a presentation, and then we'll have 15 minutes of Q&A.
Hi, good afternoon. I wish I could be with you today in California. It's a little sleety and gray over here in the Midwest. We're on slide 1 of my presentation, and I'm really pleased to address your distinguished committee today and your guests. I'm going to share with you some information about the Health Resources and Services Administration, or HRSA, funded health centers that I hope it will inform your work. Could you advance to slide 2, please? HRSA is an agency within the United States Department of Health and Human Services working to improve health outcomes and address health disparities through access to quality services, a skilled health workforce, and innovative, high-value programs. You spoke with my colleague, Laura Cheever, about the Ryan White HIV/AIDS program just a few months ago. Slide 3. The Health Center program improves the health of the nation's underserved communities and vulnerable populations by assuring access to comprehensive, culturally competent, quality primary care services. Next. There are 1,400 health centers operating a total of 12,000 service delivery sites that serve more than 28 million people. Sites are in all 50 states, as well as the Pacific Islands and territories. Next. Health centers must provide comprehensive primary care services to high-need populations or communities. To ensure effectiveness, they are patient-directed organizations that do not turn anyone away from care and must meet quality metrics. They collaborate with other community providers to maximize efficiency. Next. Health centers operate in communities and care for individuals who may be at risk for sexually transmitted infections and probably less likely to seek preventive services or treatment. You can see here on slide 6 that we care for 1 in 12 people, 1 in 9 children. We're highly saturated in areas of rural locales. We also are treating more and more veterans every year, as well as those who are migrant agricultural workers and homeless. Next. Health center performance is monitored in part by an annual report in HRSA's uniform data system. These data are used by health centers and HRSA to track growth and impact, ensure program compliance, make funding decisions, and identify technical assistance needs. You can access the data yourself through the URL on the bottom of slide 7. To help you better understand health centers' impact on sexually transmitted infection and disease, we'll look at some of the data and trends right now. Slide. The 3 groupings presented here are HIV linkage to care and cervical cancer screening for 2016, 2017, and 2018. HIV linkage to care is a newly diagnosed patient who receives follow-up treatment at the health center or elsewhere. Cervical cancer screening is for women 21 through 64 years of age as appropriate. And you can see that these values have remained pretty steady over the period displayed of 2016, 2017, and 2018. Next. Sexually transmitted infection diagnoses have increased across health centers from 2016 through 2018, as have related infections of HIV and hepatitis B virus. Next. Substance use disorder can be associated with an increased risk of sexually transmitted infection. The prevalences of alcohol use, tobacco use, and other substance use have increased since 2016 in health centers. The Uniform Data System substance use disorder metrics evolved over this displayed 3-year period. Therefore, this slide 10 shows an aggregate metric for substance use disorder. Next slide. The number of health center patients receiving substance use disorder services has increased by 58% since 2016. And enabling services such as case management, translation, patient education, and transportation have increased by 4%. HRSA has made substantial investments to support needed expansion in these areas. Next. Health centers have the personnel needed to provide sexually transmitted infection prevention and treatment, including physicians, advanced practice nurses, physician assistants, and certified nurse midwives, as well as personnel who enable patients to participate in their health care, such as case managers, educators, outreach workers, and translators. Next. Improving access and participation in healthcare is a constant focal point for health centers. HRSA supports the expansion of telehealth services as allowed by federal and state laws and regulations. Next. Health centers using telehealth for patient care is increasing, and HRSA provides technical assistance to support them. More granular uniform data system telehealth metrics were introduced in 2018. Therefore, you see some metrics with only 2018 data points on slide 14. Next. HIV screening and treatment occur at health centers, which also creates the opportunity to test for and educate patients on other sexually transmitted infections. Next. As a result of the Ending the HIV Epidemic, a Plan for America, new financial and technical assistance resources for health centers to support HIV diagnosis and prevention made available. Next. Over its 10-year course, the initiative will leverage several health center strengths, including established community-based partners, use of integrated care models, and providing a trusted point of access for patients with the greatest unmet healthcare needs in the nation. Next. Through the Ending the HIV Epidemic initiative, HRSA is currently competing a funding opportunity for select health centers to increase the number of patients, new and existing, who receive HIV prevention services, including PrEP. Applications are due today, and awards will be announced this spring. Awarded health centers in good standing will continue to receive this funding to support ongoing HIV prevention activities. HRSA anticipates that this initial modest investment of $50 million will grow significantly. For example, within the first 5 years, we do expect this program will expand to all of the health centers. Just 200 health centers are eligible for this cycle. Next. HRSA supports a variety of technical assistance to maximize health center performance. 3 examples addressing HIV are provided on slide 19. HRSA funds Fenway to provide train-the-trainer education. The High Tech Center helps health centers improve health information technologies that will support their clinical activities. And the AIDS Education Training Centers provide regional comprehensive technical assistance that's available to health centers. And these are just 3 examples of HRSA-funded centers working in HIV. We have others in other clinical areas too. Next. HRSA develops and publishes technical assistance itself for critical topics, such as the web pages dedicated to HIV that are audience-specific. As you can see here from the snapshots on slide 20, one is a HRSA-level publication, and one is actually embedded within the health center program website that are specific to the health center community. Next slide. HRSA also publishes the Primary Healthcare Digest, a weekly bulletin for the health center community and its stakeholders. Quarterly, a special edition is published on a hot clinical topic. These editions are written by clinicians for clinicians. There is one, for example, on intimate partner violence and human trafficking. Both of these topics addressed in this special edition are relevant to the STI prevention and treatment. If you're interested, you can access this particular special edition through the webpage. Next. And there's also a special edition on the opioid epidemic, again relevant to your area of focus. If you're interested in learning more or reading more of the digest editions, you can sign up for the digest via the URL on slides 21 and 22 of my presentation. Next slide. I wanted to spend most of my time answering your questions. I hope that this information gives you a little bit of foundation or brushes off some cobwebs from your existing knowledge of the health center program. I'm available to take questions and make any other comments that would be helpful to you.
Thank you very much. Dr. Hook.
Dr. McDevitt, my name's Ned Hook. Thank you very much for your presentation. As I think about the health center program, my suspicion is that, like most primary care providers, the people who are working in your centers have more recommendations to deal with than they can handle. Does your program have a specific mechanism for helping them to prioritize or to measure which areas are prioritized? I realize that the additional funding that you just made available for PrEP and the like does represent a prioritization, and money speaks. But what about for other ways of prioritizing the activity of your providers?
Absolutely. We do a lot of that through technical assistance. So we also will embed priorities from the administration, for example, that into our existing funding opportunities. So, for example, while we had the funding opportunity that you mentioned that really focuses on increasing access to PrEP, with those preventive services, we can use those funds to address other HIV prevention as long as they are fulfilling the requirements of that funding opportunity. So we embed those other priorities that we identify as being important and directly related to the purpose of the funding opportunity. So that's one example, and also through the technical assistance that we avail to them and that we advertise in the digest. And you're right, they certainly cannot address everything. The health center program is distinct, for example, from the, you're familiar, I'm sure, with the federally qualified health center nomenclature used by the Centers for Medicare and Medicaid Services. They must continue to adhere and report on all of their CMS metrics. We align the UDS, or Uniform Data System metrics, what CMS is doing, but they do not report on all of the CMS metrics through our systems. And so then again, those that we are cherry picking as their clinical quality metrics that they report for the health center program are also sending a message to our health centers.
I apologize, I should probably know the answer to this, but did the FQHCs also follow their metrics through the HEDIS guidelines or not?
Again, it's a little confusing because the health centers are FQHCs. There are other centers that are also federally qualified health centers, such as our rural health clinics. Health center, HRSA-funded health center is distinct federal language from the federally qualified health centers, which is really a CMS reimbursement category. So the health center program does not remove any reporting requirements for health centers if they are participating, as all of ours do, in Medicaid. More and more are participating in Medicare. They must continue to fulfill those requirements as dictated by other quality and reimbursement organizations. Does that help?
So they do report according to the HEDIS guidelines?
They do. Mm-hmm.
Dr. McDevitt, this is Jeff Crawley with Georgetown Law. I have a question. Some have wondered if we have adequate capacity to fund STI treatment in the United States, and people have looked for different models to do this. I'm sensitive to the fact that we ask a lot of health centers, but you also operate migrant health centers, programs for people who are homeless. I'm wondering if just in general terms, how do these programs differ? And if one were to consider a more tailored program specifically to address STIs, are there key things we should think about or ways we might want to differentiate it from the broader health center program?
Okay, so the health center program has four types of health centers. You're correct that it funds. There are the community-based health centers, the community health centers. There's the migrant and seasonal agricultural. There are health centers that are specific for homeless populations, as well as public housing. Now, those are statutorily defined, as Professor, you identified, of course, but they do receive funding through those different statutory levels, but independent of their funding, whether it's health centers for the homeless, public health, migrant, or community health centers, they all have to respond to the same health center requirements. So those health centers that are specific to the homeless population, or those who have homeless patients as one of their population types, there's no difference in the reporting or the requirements that those two types of health centers have to do.
Is there
Do
a
I
separate
understand your
appropriations line for
question
each of those programs?
Not typically.
No.
So normally when we have two lines of funding. We have discretionary and non-discretionary, and that usually comes just for the 330B health center program. Typically, if there is funding that is going to benefit one of those population types that is aligned with a funding line, then that is specified in the budget bill. We don't typically, I can say in the past few years that we have not seen that. The funding has come from at the health center line, and if there are specific requirements made with that funding, they are typically clinically directed. So, for example, the ending HIV epidemic, $50 million for fiscal year 19. We know the opioid epidemic response funding that we've had in 2016, 17, 18, and 19. All of those have been tied to clinical focus areas.
Thank you.
Hi, this is Alina Salganikoff with the Kaiser Family Foundation. I was curious about the UDS and your data capacity there. I noticed that you didn't present any a lot of the kind of other STDs, kind of non-HIV STIs that we're looking at here in the committee, and I'm just wondering, is that available? I know I've done some work with the UDS, so I know that there are kind of some limitations. Is that available, and can you also stratify by some of the subpopulations at all? Just wondering if we can learn a little bit more about what the health centers are doing.
We actually have a whole division. Sure, I'm sorry, I didn't mean to jump over you there. We definitely have an entire division that is dedicated to handling UDS queries. Those data are available through the website. And if there's a particular question that you're interested in, our data team is available to help with that. So we have an inbox, and if you go on to our epidemic.HRSA.gov, that's Bureau of Primary Healthcare, BPHC website, and migrate over to the data tab, you'll be able to contact the team through there. And you're right, our health centers are required to report on many metrics. We are trying to improve the uniform data system through a whole modernization and 3-year initiative to ensure that our metrics are aligned with, for example, clinical quality metrics that CMS uses and others, so that it decreases the burden of reporting for the health centers. We receive requests regularly from all different groups that ask us to add metrics to the UDS for the health centers to report on. We have to be very strategic in which we select, and so we try to be just to be fair, as well as to be responsive. So if you have specific recommendations from this committee about what metrics the health centers are reporting on as it relates to sexually transmitted infections and diseases, then those can certainly be submitted directly to our data team for consideration.
And then
And I can tell you too that HRSA does not make those decisions independently. We have a UDS stakeholders committee that is representative from the public as well as from the health centers that gives us guidance into all of the critical uniform data system decisions.
And then the other question I have is on a whole different topic, which is I know that there's a sizable share of health centers that also get funding for Title X that provides support. And can you talk a little bit about what that funding enables some of the clinics to be able to do around STIs? Do you have a sense of that?
The Title X funding, it depends on what the health center is using it for. Depending on the services that the health center is providing, they may be required to have very physically separated spaces, because the health center program statute is very clear on the fact that health center program funding cannot be used in any way to support abortion services.
No. I was more interested in just that.
Health centers to
More around, is any of that funding used also for STI training, or are you using any of that fund for some of those services? Because that is part of the purpose of that funding as well.
We have
Or
not,
how that's
to my knowledge, we have not directly tracked that.
Okay.
We work closely with the Office of Population Affairs, which is where this money is directed from. And we know that some Title X programs are federally qualified health centers and some have other diversified funding streams. But under the current guidelines that OPA has, STD testing is included in what they should be providing.
I was more interested in just trying to see also, like, not just the testing, but I know that the Title X funds can also be used for training, supporting other systems. And so I was just wondering to the extent that that's ever been looked at as well.
Yeah, I think that
outside of
training
that.
comes from our training centers more on the STI side. They expect our training centers to do that, and they fund more the
For the contraceptive training. Okay, thank you.
Thank you for the bailout there. I appreciate it.
So I wanted to ask that if we would like health centers to play, say, a larger role in STI testing, prevention, and treatment, what should we do? Is it just earmarked funding? Is it something else? What would your recommendation be?
Well, certainly having STIs tied to funding is helpful. It will give us a directive that we frankly can't ignore, and we can speak very directly to. Now, creating new funding for the health center program sometimes can be challenging. So there's a lot of momentum behind the ending the HIV epidemic. And while the health center's role has really been tapped to increasing access to PrEP and playing in a tandem partnership with health departments that are doing testing, referral to treatment facilities if they are not doing HIV treatment. More and more are doing that as it's really seen as part of primary care. I think that there may be an appetite to consider how HIV prevention is more fully integrated into the comprehensive primary care that health centers are providing. We in the past have had investments to support HIV care integration into health centers. And so I think that playing off of that history and that momentum to say, you know, we're very interested in health centers' role with HIV, but that is part of a larger conversation that is about comprehensive primary care, which includes screening for all sexually transmitted infections. It includes patient education about, gosh, if you have a sexually transmitted infection, you're increasing your chances of becoming infected with HIV. There's been a lot of investment over the past 3 years with the substance use disorders. And so how do we think about other comorbid infections and conditions that occur? So I think that these are examples of how to play upon the current appetite and to see the relationships between your area of focus and the priorities that have been established by the administration and Congress. Is that helpful?
Thank you. Before we end this session, I wanted to check with our remote committee members to see if any of them had questions.
This is Sten Vermund. I just wanted to ask you, in integration of HIV and STI services, you alluded to that more as an opportunity. Do you believe that the health centers are doing a reasonable job with STI screening tied to their HIV screening and their HIV services, or do you think more needs to be done in that regard?
I think there's opportunity. I think that there's an opportunity to learn more about their performance, as well as an opportunity to support them in doing more.
If there are no more questions, we'd like to thank you, Dr. McDevitt. I'm sorry, I'm tripping on your name. Dr. McDevitt. I appreciate it so much. Thank you for your time and for your presentation. Thank you.
Thank you for the opportunity. I hope that it was helpful information.
Thank you.